how to face the examinations and all. How to approach a PG exams. The most important is not difficult, provided we should prepare ourselves to face it. How to prepare for theory, most important, you have to keep on reading textbooks and you have to prepare notes, and undergraduate textbooks also you are supposed to read well, then other books also if possible you can read. Whatever you read, no, you have to, whatever subject you are reading, you have to make notes. How to prepare clinical exams. We have got so many patients will come and you have to face the examiners. To prepare yourself for clinical examinations, you must see all the patients and try to present to your seniors or to your professors. That's the most important thing. You see patients and prepare yourself and face the examiners daily. Almost, if possible, try to present the same patient to different examiners. One more thing, after reading, before retiring to bed, recollect whatever things you have studied throughout the day so that you can remember better. And one more thing, by reading, you will not remember anything. You have to teach others. By reading, you tell others what you have read and try to explain. If you are not able to find something difficulty, you consult your seniors. They are there to help you. And when you write exams, these are all for preparations. When you write theory exams, your handwriting should be good. Nobody, I'm telling you now, you are going to write for 3 hours, but we hardly take about 10 minutes to correct your entire paper. That's why handwriting should be good, legible and impressive. Wherever you want, you can draw diagrams. The most important thing is. And don't write pages. Nobody bothers about pages. Please remember, nobody bothers about pages. Suppose in clinical examinations, most important thing is what? Don't be panicky. And one important advice, you must not take any clue from anyone. Even if assistant professors are inside the exam hall, don't take any clue because it may misguide you. Understand now? Never take clue. And moreover, a student has given his examination is coming out, don't ask anything to the student. You will be misguided again. So better option is what? You read, you see the patients, elicit the signs, elicit the findings and all. Not able to come to a conclusion, you tell these are the possible problems, possible signs, my most probable differential diagnosis is this, that's enough. Don't bother about your exact diagnosis. Nobody bothers about your exact diagnosis because nobody knows. Understand now? That's the most important thing. So you have to prepare differently. You must tell some few points about each. That's enough. Never examine when you're given a case, examine both eyes. And never forget, as far as parapto is concerned, Niranjan is going to talk about that. You are supposed to examine ENT, never forget, and other systems like even genitals, breast tumors and all you are supposed to examine. This is the most important. Clinical examination should be good. Don't bother about your diagnosis. Don't bother about suppose management part and all. If you will learn all those things in future. But for exam purpose, you must know how to present the case, elicit the findings, never miss the findings. That's enough. Thank you. Best wishes. Yes, now I request Dr. Vanilla to present vanilla. Vanilla. Vanilla no chikla. Okay, please come.
Good morning. At the outset, I would like to thank Dr. Vijay sir and my friend Dr. Chandrasekhar sir to giving me this wonderful opportunity. As you all know, when any anterior segment case presentation, we write notes like this. But if you face abnormalities, anterior segment, you will not start with the slit lamp. You start with the phase, whether it is asymmetrical or the whole phase abnormalities you might miss if you go to the slit lamp first. So look for any, each of these can be a separate case for you. So whether it is ptosis, lid tumors, lag of thalamus, blepharophimosis, lid retraction, all this should be examined before going to the slit lamp. Or any phase abnormalities, the whole phase abnormalities should be seen, and whole eye like should be examined, like if microphthalmus, microcornea, all this before going to the slit lamp, please see. The lids, look for any abnormalities. I'll be talking only on the abnormalities, whether it is ectropion, entropion, symblepharon, make a note of it. And the discoloration of eyelashes will give you a clue that is scoliosis. Look for the adnexal swelling. If it is present, look for rhoplast, and what kind of regurgitation is there, whether it is mucus, mucopurulent or watery. In the conjunctiva, whether it's clear or congested, you have to look for. If it is congestion, whether it is a conjunctival congestion or circumcorneal congestion, the difference between the two is the commonly asked exam question. The fornix, look for any follicles, and avert the upper eyelid and see for papillae. The other common exam question is the difference between the papillae and follicles. Follicles are seen in infectious conditions such as trachoma and your viral keratoconjunctivitis. Papillae is more in the allergic conjunctivitis. Other exam spotters will be conjunctival degeneration such as pterygium, nodule at the limbus. Look a sharp look at the nodule. If it is a dermoid, then look for preauricular tags so that you can be discussed on the golden hair syndrome. If there is a growth, you will be missing a OSSN, then you should be able to see the extent of the tumor and describe what the conjunctiva looks like. The sclera, look for any nodule, whether it can be a nodular episcleritis or scleritis, or a diffuse congestion as in scleritis, scleral thinning, necrotizing variety of scleritis. So the systemic association should be coming into your mind, or a scar with scleral thinning or staphyloma. In the staphyloma, you will be asked about various varieties of staphyloma. Cornea, when you describe cornea, take care you come in layers. In the epithelium, where there is a defect, ulceration, or epithelial bullae. Or in the stroma, if it's a diffuse stromal edema or a racemate folds. And in endothelium, you should look for guttata, or if there is any pigments or KPs. If cornea is clear, it's okay. If its cornea is having opacity, try to describe the opacity, whether it is a band-shaped keratopathy or a leucoma, whatever opacity is there, you will be asked about the different type of scars in the cornea. If the opacity is associated with vascularization, you will be asked about the deep vascularization and superficial vascularization. And if it is superficial vascularization, you will be asked about progressive and regressive pannus, and condition producing the opacity with vascularization, stromal keratitis or interstitial keratitis. The picture to the right is opacity in a congested eye. There is a ulcer over the opacity, so we should be thinking of atheromatous ulcer. So the discussion will be on atheromatous ulceration and the treatment. And other keratitis which can be kept in the exam will be ulcerative keratitis, which is microbial. It can be viral, fungal or bacterial. If the epithelium, you have to stain with the fluorescein, look for any forms, like if you have a dendritic form, we will be dealing with herpes simplex keratitis. And in an ulcer, describe the size, shape, margin, extent of the ulcer, whether it's associated with hypopyon. In the iris, look for abnormalities which should be sought is the coloboma. In progressive iris atrophy, you can have polychoria. In any trauma case, a D-shaped pupil and iridodialysis should be sought. And in the pupil, if you have any ectropia and UVA, that should be noted. If the iris is atrophic, you should know which type of iris atrophy is there, whether it is sectoral or diffuse. All iris atrophy, look for retroillumination, look for transillumination defects. In the patinus loss, you will have a muddy iris in chronic uveitis. And in other iris abnormality, which is frequently kept in exam, is new vessels over the iris. On to the right, there is glaring new vessels, but in the left, you can see it is a small filiform vessels in the pupillary border, which should not be missed even if it is subtle. And here the questions will be the condition causing, how will you differentiate a new vessel from an iris vessel. Any vessel which is seen on the iris is likely to be a new vessel, because normal iris vessel is usually not seen. In the pupil, the morphological abnormalities can range from occlusio pupillae, seclusio pupillae, festoon pupil, or a chorectopia or persistent pupillary membrane. There can be a combination of seclusio and occlusio pupillae, where the total annular synechiae will be present, and so that there will be seclusion, and you will have a peripheral bowing of the iris, resulting in peripheral anterior synechiae and pupillary block glaucoma. In case of uveitis, you have to see whether there is uveitis in a white eye or red eye. So you will see for circumcorneal congestion in the cornea, you seek for the keratic precipitates. The keratic precipitates, you should be able to identify whether it is fine granulomatous or non-granulomatous keratic precipitates. You will be asked about the arch triangle and the aqueous convention currents, and the iris nodule should be sort of when you see any granulomatous KPs. You should look for flare, and flare is graded by the visibility of iris from 1 to 4, and the cells also. If there are grade 4 cells, it's called a hypopion. So hypopion, how to differentiate a hypopion and pseudo hypopion is a common exam question, and an inverse hypopion will be a differential in a silicon filled eye. Other things in the anterior chamber will be hyphema. The questions asked here will be what are the causes of hyphema, and what is the 8-ball hyphema, and what are the complications. When will you get corneal blood staining or the glaucoma associated with hyphema. Lens status, describe the lens status, whether it's clear immature cataract, mature hypermature Morganian, or a subluxated lens, and whether there is associated pseudo exfoliation and amount of dilatation of the pupil because of pseudo exfoliation. If it is aphakia, you should mention about the iridodonosis. If it is pseudophakia, whether it is an ACIOL, PCIOL, or a subluxated or dislocated IOL should be mentioned. In a glaucoma case, in the conjunctiva, you look for a bleb, and the questions asked will be whether it's a filtering or a non-filtering bleb, how to identify them. In an narrow angle glaucoma, the difference between a surgical PI or a YAG PI is asked. And if it's a post-congestive attack, you have the Oakes triad with corneal edema, sector iris atrophy, and mid-dilated pupil and glaucoma flecken. If it is secondary glaucoma, look for new vessels. And then you should do a gonioscopy and grade the angle from 0 to 4 and see any abnormalities in that. And examining, you should document, do a color coding, any vascular edema in blue, and circles will denote the epithelial edema, scarring in black. If it is an ulcer, ulcer is depicted in green, infiltrate and hypopion in yellow. If the edema in blue, cataract also is in green. So these will be the cases kept. Bullous keratopathy, and if it is bilateral corneal opacity, you're dealing with dystrophy. Will be asked whether the genetic predisposition and the differentiation between dystrophy and degeneration. Ulcer, I said, in this I want to mention whether you should corneal in any case, corneal ulcer. Ulcerative keratitis, you should think of a Moorens ulcer and systemic associations of PUK. Keratoconus, Okay, sorry. Time is up. Take home message I want to look at examine the patient as a whole, check for corneal stimulation on all the mention about the pupillary reaction, whether it's brisk, sluggish, or rapid is present. Draw a diagram with appropriate color coding. Thank you.
Yes. Now I call upon Dr. Saravanan, the vitreous consultant of Aravind Eye Hospital, Coimbatore. He is of nearly 30 years experienced person, and he is going to tell you something about the post-segment examinations and how to evaluate to when you are encountering a case in future, that is in particular in the examinations.
Thank you, sir. So mainly little bit of difference between the anterior segment and posterior segment. First you have to learn to visualize the posterior segment. So sometimes some of the hospitals when you go for exams, they will not have have all the instruments. So whenever you go for an exam, make sure you carry your own set of instruments. It can be a diaphragmoscope, it can be a lens, preset preset lenses, along with your indirect and 20D lens. So always try to buy your own set of instruments and carry it with you yourself. Sometimes even if they may keep an instrument, it may not be as good as what you use, and you may not be able to see the fundus properly. So always try to carry your own set of instruments so you feel comfortable and much more less tense and much more peaceful in using your own set of instruments, because already you are used to it. So a lot of times it's just a spotter or a small short case, and it's unlikely to be a long case if you're following the old format. And make sure that you get some amount of history also. Even if it's a spotter, always ask for a history. This is actually the real thing which happened during my DNB exams 25 years ago. So we had a case of a cherry red spot, and everybody was diagnosing a CRAO, but actually it was a case of a blunt trauma. So if you ask a history, then I specifically asked for a history to just to see what was the reason for the cherry red spot. And except me, everybody else got it wrong, saying it was CRAO. Even if it is spotter, always get a short history, so it will help you to come to a diagnosis. And when you're asking questions also, and you just have a set of questions you can keep practicing during your MS or DNB course. Try to ask the same set of questions so you get used to it, and you are able to, without skipping the important history, you can ask it. If it's if a RD patient, you'll have to ask about all the 4Fs, because commonly that field of vision, failing vision, flashes and floaters. Sometimes when you go to the exam, ask what this patient had as a complaint. So make sure that you ask all the history and the positive scotoma in central serous retinopathy, and if it's vitreous hemorrhage, ask for previous episodes. So when it's a recurrent disease or a one-time disease. And also in ARMD, if you're not sure about the diagnosis, if the patient gives a history of injection, you know that's the ARMD case, because multiple injections means that the patient has got ARMD. So it's a uveitis case, or ask about systemic history, especially about tuberculosis, especially if you're in the north, it's a very common disease. And also the presence of cardiac disease if you're dealing with vascular retinopathy. And if it's a dystrophy, ask for history of the same disease in the family. And if it's a diabetes, ask for coexistent disorders like hypertension, dyslipidemia, and nephropathy, because that may sort of change the picture of the retinopathy. And whenever you don't have a proper diagnosis, VRY was pointing out, people don't expect a proper diagnosis. If you can give suggestive DDs for all, some 2-3 DDs for whatever you're seeing, that itself is enough. Don't keep a set diagnosis and try to fit your diagnosis, all the findings into that diagnosis. So again, all this, how to examine also, just go about examining all the, right from the media, vitreous, disc. So always practice the set patterns so you don't miss things in the, when you're describing also, you have to tell whether the media is clear or not, and why is the media not clear, whether it's a corneal opacity or a lenticular or in the anterior chamber like FM or hyphema, or the vitreous hemorrhage or vitritis, or posterior vitreous detachment, or all those vitreous syneresis, and all those things. Talking about the optic disc, you have to talk about the size, shape, color, and margins, and the cup, and the NRR is healthy or not. And if in the retina, you have to look at for any hemorrhages. What type of, when you say hemorrhages, just don't say hemorrhages. You say intraretinal hemorrhages, or flame-shaped hemorrhages, or dot and pot hemorrhages, or if it's a pre-retinal, subialum, or vitreous. So try to say what location the hemorrhage. Just don't say hemorrhages. A lot of times I see people saying just hemorrhages are there. You tell me what hemorrhages there are: subretinal, pre-retinal, or intraretinal, dot and blot, or flame-shaped. Mention what is, because each will have its own significance and it will point to a diagnosis. And when you have a look at the macula and what are other findings like drusen, exudates, fluid, so whatever is there, you just try to identify and describe it in a sequential manner so that if the person who is hearing it, even if his eyes is closed, he should be able to imagine the fundus which you are describing. And foveal reflex, don't say dull. A lot of people don't like it. You say whether it's present or absent, that much is enough. If it is absent, tell why it is the absent. You say edema, hole, or SRF is there, or scar, or blood, whatever is there, or edema like a CME or a DME. So whatever is there, just mention why it is not, why it's absent. So this I told you, but all the presence of the other peripheral retinal lesions you have to tell. So this is the vessels. This is the normal ratio. So 2:3 AV ratio. And mention any abnormal, especially in diabetic retinopathy, caliber, venous caliber changes can be important for finder to say whether it's a severe retinopathy or a moderate retinopathy. So, and if it is any sheathing is there, tell them it is a sclerosed vessel or arteriosclerosis or it's an inflammatory sheathing. Just don't say sheathing. Tell what type of sheathing it is. So it will give again it will be descriptive of what the pathology is behind that. And if there's any holonas plaques, still it's intraarterial holonas plaques. And look for in a diabetic retinopathy, always look for presence of new vessels and IRMA, and always a very common question: how do you differentiate clinically between intraretinal microvascular abnormalities and the new vessels? So it's a very common question if you are present in case of diabetic retinopathy. And in hypertensive retinopathy, look for any AV changes. Not skip the first order, and for the second order, just see what are the AV crossing changes and mention it. All the guns, all those findings you have to say. So drawing, you have the Amster-Dubois chart, and when you're, it is like a RD case, you have to keep it inverted to the patient's position and then draw it. The center is the fovea. The disc is just at the first gap there. If it's right eye is the right side, left eye is the left side, and the first ring is the equator. Second is the end of the retina, and third ring is the end of the pars plana. So most of 90% of the diagnosis should come within the first two rings. And if there's any CD or pars plana cyst, then you can mention in the last rung of the chart. So this is how you keep the chart, and then this is how you examine, and make sure that you are well versed with the how you go about marking the chart. So when you are not very comfortable, skip in when you see. Sometimes you can get lesions within the area which you skip. So try to see an overlapping quadrant so that you don't miss lesions in between two exams. So you look up at 12 o'clock. Ask the patient look at 12 o'clock. So see the superior quadrant. Look at the nose. See the nasal quadrant. But sometimes you may miss something in the supranasal quadrant. So just see in overlapping quadrants. So you don't miss because one of the exam my classmates she was a choroidal melanoma, and it was in a small melanoma, and she missed it because it was in between the supranasal quadrant. She just saw the superior and the nasal and forgot to see the supranasal, and actually she failed the exams also. So you have this is how you go about charting. You have to be well versed in this in your exam, and during the course only you should be able to practice this and make sure that you have a proper way of depicting all the lesions here. I just show some examples of cases. This is a temporal subtotal retinal detachment. This is how you should describe it. Mention first is whether it's fresh or old, whether it is total or subtotal, and then whether it's what type of regma or tractional or exudative, and the status of the macula, whether it's on or off, and whether it's a phakic or pseudophakic guy, and then any additional findings like the choroidal detachment. So you have how is then it's a fresh total, a subtotal regma retinal detachment with the macula off status in a phakic or pseudophakic. You can see how this one of our PGs has mentioned that in a phakic eye. So this is how you should, when somebody asks for a diagnosis, you should include all these points so that it will tell you in one go. So what type of RD it is. So this is a case of vein occlusion. We tell whether it's fresh or old, is whether it's central branch or macular branch retinal vein occlusion. If it's a CRO, you have to mention whether it is ischemic or non-ischemic from the vision, pupil, and other the fundus appearance of hemorrhages are more or less, and the disc edema if it is there, and macular edema if it is there. And mention, you can say that if the CRVO on a hypertensive patient or a dyslipidemic patient, you can just tell that. And additional findings like new vessels or vitreous hemorrhage. So if it's a macular hole, then you should tell what's the cause of the macular hole, whether it's a full thickness, partial thickness, or pseudo hole. Whether it's a chronic means you'll have a RP degeneration with the elevated SR, because of chronic SRF, because of the elevated edge of the macular hole. And also you can just say it's a half disc diameter or one disc diameter, because you don't have OCT, you cannot say the actual diagnosis, actual diameters, but you can just say the comparison to the disc. So if it's a diabetic retinopathy, you have to tell whether what type of staging from the ETDRS staging, and whether it is CSME is present, because DME is from the OCT, so you have to tell whether CSME is present or not. You have to know how to describe diagnose CSME, whether it's present or not, and any additional changes you have to mention that also. Just I give you some examples from our own hospital where PGs have drawn this. You can see the ARMD with the subretinal hemorrhage. This is how we depict the central is a fibrotic greenish scar with the red blood, and this is a supratemporal RD. This is how they have depicted the macula on RD. You can see the large tear, horseshoe tear. This has been depicted like this with the inferior infranasal lattice. And this is a post-operative gas inside, so you have to put it in green. Any vitreous opacity should be in green, and inferior you have the barraged lattice mark. And this is a preatal hemorrhage in a patient with NV and preatal hemorrhage in a patient with the PDA which has been already laced. So I'll just stop here and try to present from your memory. Don't if you're not remembering, you can ask for the chart and describe from that. And I just already mentioned this. So best of luck from whatever exams you're taking. Best of luck. Thank you.
Again, I'm going to present something about how to face a neuro-ophthalmic case in the exams. Hope some PGs are here, or all PGs, postgraduates. Don't worry. And then problem here is what? When you face a case of neuro-ophthalmology, naturally you are getting some nervous. That's the most important thing. Like a squint also. But don't bother about that. All these things are very easiest subject in the whole world. Only glaucoma and all is not nothing. So neuro-ophthalmology, squint and all very easiest subject, one of the easiest subjects in the whole world. So never forget about that. It's like a mathematics. You can easily overcome that. So when as in any examination, they have got history. Visual loss, is it transient, or double vision is there, periocular pain is there. Then we have got visual loss when it's there. Everyone knows, you are supposed to write visual loss or diminished vision, gradual, sudden, like that you're going to write. But most important, sudden means what? What do you think about the sudden vision loss is there? Mostly what now? Ischemic problems. Something block is there. Suppose gradual is there, maybe something corneal problems. Like that you can think. You understand now? Even cataract also you can have a gradual loss of vision. So unilateral and bilateral, most important problem. Unilateral visual loss means usually a problem is up to chiasma, before chiasma. Whereas if it's a bilateral problem, starting from chiasma onwards both. Posteriorly, it's bilateral. And you have got changing the exercise during exercise. Suppose the patient tells you, say, I take bath, my vision is getting reduced. What's the is called? Classical optic neuritis case, multiple sclerosis. Multiple sclerosis, that is called Uthoff sign. What is Uthoff sign? When you take bath or increased body temperature, the vision is further getting deteriorated. Now the question is what? Why do you get this? They will ask you. Your answer is, sir, when you take exercise or something, the body temperature is increasing. Now there will be edema, the plaque is in the demyelinating problems, they get edematous. They compress your optic nerve further. Number two, we have got so much of chemical substances are getting released. Environment is changed. There's a conduction delayed. That's all you're supposed to tell in the exam. The reason for Uthoff sign. Transient loss. Transient loss lasting for a few seconds. Never forget about intracranial pressure increase. Papilledema patients. They will ask you why in papilledema you got a transient loss. Very simple. Whenever there is a raised intracranial pressure, there will be spasm of the ophthalmic artery or the posterior cerebral artery. So naturally the blood supply to my visual cortex is reduced. That's why transient loss is there. That's why papilledema patient can have transient loss. Whereas suppose the same transient loss lasting for a few minutes, never forget migraine. These two things, just transient loss lasting for a few seconds, then a few minutes. Never, as an ophthalmologist, never forget, transient loss can also occur in a case of previous attacks of angle koshak glaucomas. That's the most important thing. Transient loss of vision can occur in glaucoma patients also. Double vision, just to close one eye and see. Double vision disappears. That's called binocular diplopia. Only when both eyes are open, diplopia is there. When one eye closed, diplopia disappears. It's a case of neurology problems, neuro-ophthalmology problems. When I close one eye, the diplopia persists an ocular problem. That's all. It's very simple. That means when you close one eye, diplopia disappears means the problem is starting for us. You have to investigate further. When you have a closing one eye, diplopia disappears means problem. When disappear persists means a uniocular, maybe an ocular problem like subluxated. So many things are there, lenses and all. These are the commons you are supposed to know. Fluctuating, suppose the patient tells you, sir, I'm having morning diplopia, evening no diplopia. Never forget myasthenia. You know one important point? As a PG, suppose you are not able to come to a conclusion for anything. You are not able to come to any disease, something, diagnosis. Tell in the exams, sir, I want to rule out myasthenia. Finished. Don't bother. You can tell straight away. Suppose you are not able to come to a conclusion, you tell, sir, I want to rule out myasthenia, but you should know how to rule out. That's the most important. Understand now? You should know what is neostigmine test, so many things you are supposed to know. Then pain and movements, classically optic neuritis case, irritable neuritis case, they can have what's called Whitnall hypothesis, that's called Whitnall. That means optic neuritis inflammation is there, the dura mater is there of the superior rectus and middle rectus. When the optic nerve, when the muscle contracts, optic nerve is pulled, experience pain. That's why in elevation adduction, person experiences pain in the case of optic neuritis. History of oscillopsia. Please remember, a patient got nystagmus from birth. He will not experience oscillopsia. He will not experience. Suppose nystagmus occurs acquired. Now, recently, he will definitely he experience oscillopsia. Means if the entire world environment is moving for him. Naturally, he will have what? Nausea, vomiting, so many nonsense. That's the problem. This is called oscillopsia. See, now the world appears like this for the patient. Ptosis variable, suppose ptosis patient there, variability, straight away tell myasthenia, that's all. Straight away tell myasthenia. Can you see now here, one patient is got, now they have tested now neostigmine, the ptosis improves. Now patient comes to your outpatient department, he is having an hemiplegic gait, think about Weber syndrome, and he is having ataxic gait, maybe cerebral problems, and he is having a tremors and all, he is having midbrain problems, Benedict syndromes. The head posture, see head posture, just by seeing right and left, tilt and all, you can tell which muscle is involved. Straight away you can tell. Suppose my right head is turned towards right side, my right lateral rectus or left middle rectus, straight away you can tell. Chin is depressed, I know superior oblique. Chin is elevated, superior rectus. Straight away you know that this muscle is involved. By seeing the patient, you can tell there is a problem with the patient. Understand now? Eye examination, never forget. I have seen students, you are an ophthalmologist, you are supposed to write vision first. When you're starting eye examination, of vision first. Don't write vision last and all. You'll get confused in the exams. I have seen students missing taking visual acuity. Leads measurements of ptosis, Marcus gun phenomena, whether it is there or not, congenital ptosis, patients, Marcus gun phenomena is there or not. You know what is inverse Marcus gun? Hello, PG, you know what is inverse Marcus gun? When you open the jaw, the lid is normally opening, here it is closing. This is the Marcus gun. You see now, opening the jaw, the lid is opening up. When you open the jaw, the lid is coming down. It's called what? I don't want to ask Niranjan. Hello. Niranjan is a quiz master. It is called as Amerine-Amott phenomena. Amerine-Amott phenomena. Movements you are supposed to know, all the movements you are supposed to examine, pursuit, saccadics and all. Adduction, when you do right and left gaze, you see the eye is adducting or not, problem is there or not. Abducting gaze shows nystagmus or not. That means you are dealing with a case of internuclear ophthalmoplegia, that's all. Right side internuclear ophthalmoplegia means right eye adduction problem. Left eye means left eye adduction problem. Other eye will show nystagmus. Can you see here? Right eye is not adducting, left eye is showing nystagmus. This is called right side internuclear ophthalmoplegia. And of course, when you examine, always when you see the movements and all, see the position of lids, otherwise you will miss the Duane syndrome. Hey, you know one thing, never hold the lid and see the movements. If you hold the lid and see them, you are going liable to miss. Just see and like that left, that's all. Don't hold the lid and see. If a ptosis case there, don't hold and see. You will have problems. So always see as such. Don't hold the lid and see the movements. You're liable to miss so many things. Up case, same thing. You see, it's called retraction nystagmus can occur sometimes when you move two movements, they can have retraction. That's all midbrain problems. Cover test and non-cover test you are supposed to know. Can you see now? Right eye deviated. You are covering left eye. The right eye comes and takes a fixation. Now, understand now, the left eye, you are like this, These are all you cannot coming under strabismus cases. But never forget, paralytic squint also you are supposed to do cover test and all uncover test. You are supposed to know primary deviations, second deviations. Like this, all these things you are supposed to know. Sensations, pupil, never forget about pupil. Pupil is your hello. Unless you examine pupil, you are finished. Can I ask one question before me finishing? What is the size of pupil during sleep? Any PG can answer. During sleep, what's the size of pupil? Because the time is running. Hello. Hey, dark room, man, you are sleeping. You tell something. Please remember, don't take dark room at all. When you sleep, the sympathetic system is knocked off. Sympathetic consoles your dilator muscles. So the only the parasympathetic is working. During sleeping, it is constricted wherever you sleep. Number two, death time. You know death. When a patient dies, what's the pupil size? You always tell what? Dilated? Dilated only, you're measuring people alone. Dilated, only 1 minute. Hello. Dilated. Now you see, we'll ask you, morning 8 o'clock, patient is dead. Now night, 8 o'clock, what's the people? Night time when you go and see him, is it rigor mortis? He will have rigor mortis. Now the rigor mortis, all the muscle contracting. What about the people will ask you? Never forget, pupil is what? Involuntary muscles. Rigor mortis affects all the muscles, That means the pupil constrictor muscle is powerful. Pupil is constricted during rigor mortis. Never forget this point. Pupil is constricted during rigor mortis. That time, when you suppose you go and see the patient, that time, don't tell he's alive. Please remember, he's dead. Thank you very much. Hello. Now I request Dr. Niranjan Karthik to talk something about proptosis. He was one of our students, great quiz master. He has nearly 100 quiz. Yes, I think he got medals.
Very good morning and a warm welcome. And a very warm welcome to our instruction course where we'll be dealing with the intricacies of clinical case presentations. So first of all, hats off to all of you to be here early this morning in spite of inaugural dinner yesterday running late. So without further ado, let me quickly start with my topic for the day, which is proptosis case presentation. We've dealt with about the anterior segment, we've spoken about the back part of the eye, the retina, the optic nerve, and now we are heading towards coming all the way to the front and trying to assess a case of proptosis. So proptosis is a very potential case for a topic for a long case in our examinations in post-graduation because it has a ton of findings that you are expected to identify as an ophthalmologist merely clinically, and that was the way to go in diagnosis in earlier days before the MRI and CT was very easily available. So at the outset, I would like to thank my teachers, VRV sir, DC sir. I mean, to share the podium with my teachers is a phenomenal, it's a surreal feeling for me. So thank you, sirs. So let's get to some basics. So definitions first. Protrusion of the globe more than 22 millimeters beyond the orbital rim is the simplest way to go about defining proptosis. Or when we speak about asymmetry between two eyes, difference of more than 2 millimeters is suggestive of that. Now getting to the intricacies part, the examiners have a very liking towards these word juggleries and asking you the difference between proptosis and exophthalmos. So after, as a PG, even this question quite intrigued me because it was difficult to find a proper source to answer this. However, overall, the conclusion was that proptosis is believed to be a passive phenomenon where there is a push from behind the globe irrespective of the underlying etiology. On the other hand, exophthalmos is more often than not reserved for a case of thyroid orbitopathy. And very important to proceed, to do before proceeding further is to rule out pseudoproptosis. Like in case of ptosis examination, where we have pseudotosis, it's crucial for us to not miss out pseudoproptosis. So it can be divided into the eye that is under evaluation or an abnormality with the contralateral eye as well. So if the eye is highly myopic, or if there is a lid retraction in that eye, so that could give a false appearance of the eye being proptosed. On the other hand, if the contralateral eye is suffering from enophthalmos, ptosis or phthisis bulbi, again it could give us a false opinion as to the normal eye being proptosed. Now, for enophthalmos and phthisis bulbi, one important sign, as I've shown in this picture, is about the deep superior sulcus, which is a very crucial sign suggesting of a contralateral enophthalmos rather than the normal eye being proptosed. Now, history taking is the cornerstone, like in any clinical examination, and there are 2 points I've put in red, mainly because this is a very, very crucial indicator of the severity of proptosis. So, watering, photophobia, and loss of vision or diminution of vision are suggestive of quite advanced stage of the disease that we are, of proptosis that we are in evaluation. And diplopia, redness and pain could also be presenting manifestations. So age of onset is crucial in children. It is restricted to orbital cellulitis or tumors like rhabdomyosarcoma in young adults, and in the elderly it is different, with thyroid orbitopathy and pseudotumor being common in middle-aged and malignancies being common in elderly. Now the onset again gives us very important clues of whether it is infectious or inflammatory in etiology, or we are talking about a chronic smoldering pathology like dysplasia or even benign tumors. Important to remember that malignant tumors or tumors that have undergone a malignant transformation are expected to have an acute or a subacute course. So that is something that one must not miss while speaking of the onset. So progression, slow progression, benign tumor, chronic thyroid orbitopathy, things being intermittent is highly suggestive of periodic orbital edema or a pathology having sudden changes like recurrent orbital hemorrhage in cases of lymphangioma and so on. Rapid progression, highly suggestive of malignancy and infection. Painful or painless is crucial, and it gives us a fair idea as to what's going on. And laterality wise, unilateral can be tumors or vascular abnormalities, whereas thyroid, IOID, idiopathic orbital inflammatory disease, could be bilateral. Certain special characteristics that one must not miss is this is pretty much complained by the patient. That is what I wanted to highlight here, is the pulsating feeling which is seen in AV malformations, transmitted cerebral pulsation seen in congenital meningocele, where there is a direct communication to the intracranial cavity. Past history, systemic conditions like thyroid eye disease can be a very good indicator. Malignancy, and lastly, the past surgical history where there is a chance of recurrence. Now, examination is quite detailed. So we have to start with general examination, just like in any other case, and not to miss out on crucial signs of Graves' disease and other things like malignancy where there is sudden decrease in weight and so on. Ocular examination start with visual acuity, which is the most important aspect for any ophthalmologist. And moving on to the eyeball, it can be divided into these headings, beyond which we have to examine the other parts of the eye as well. So starting with inspection, so it has to be done from all angles, front, side and above. This is known as the Navziger's method, where we are trying to assess the extent of proptosis, and the worm's view is what we name it when we see it from below. So if it is axial, these are the common differentials, and non-axial, depending on the direction to which the globe is pushed, it can be classified into these 5 types. And check the ocular motility, because the involvement of extraocular muscles or the nerve supply could be an indicator. Periorbital inflammation is suggestive of conditions like orbital cellulitis. Certain special maneuvers like Valsalva can give us a clue as to what is the tissue that is involved in resulting in proptosis. Now this is again a very fascinating thing for all the examiners, is the lid signs. I will need a separate IC per se to discuss this in detail, but one way to go with it is try to categorize it into different parts which are involved, and that helps us sort of remember at least a couple of them, and try to revise it before your day of exam can help us remember better. Now moving on to the palpation part, remember that certain ways of how to do it is crucial. So starting with the finger insinuation test, remember that it can be asked by the examiner to be demonstrated on the patient. So things that they look for is that you have to ask the patient to look away from your site of insinuation. Like for example, let us say you're trying to insinuate and see for the gap between the superior orbital rim and the globe, in which you are asked to request the patient to look down. Why? Because it relaxes the orbital fascia and allows you to better palpate the mass which can get protruded out and made more conspicuous. And retropulsion is a very important thing, as we can see in the top picture here. Yes. So as you can see here, this is where we use the tips of 5 fingers all put together and try to push the globe and expect for resistance that is offered by the retroorbital mass, and a firm consistency suggestive of a retroorbital space occupying lesion. It could even be engorgement of the extraocular muscles by the deposition of GAGs, glycosaminoglycans, in thyroid eye disease. Orbital thrill and pulsation it is examined using the index and the middle finger over the closed eyelid, and there are 2 types, true and transmitted. And swelling, important to assess for 5 signs of inflammation: tumor, dolor, calor, functional lesia, as we've learnt in surgery. Regional nodes examination absolutely crucial. to look for any secondary spreads to the adjacent lymph nodes. And reducibility of the mass is suggestive of vascular etiology. And infraorbital anesthesia, again crucial, and check for the cheek area sensation for lacrimal nerve. And last but not the least, auscultate. Again, the trick here is to use the bell and not the diaphragm of the stethoscope to look for bruit in AV malformation. Transillumination is another phenomenon where it is done using pen light, and it is suggestive of whether it's a solid or a cystic mass. Last but not the least, very, very important is exophthalmometry. Do not jump to diagnose each case as axial. Do your two-ruler method, for which you just need a couple of rulers. Make sure that it is absolutely axial in nature before we jump to do the exophthalmometry with Hertels or any other gold standard methods. So what are the different types? So two-ruler is done in the fashion shown here, where we measure the horizontal and vertical displacement of the pupil from the center point and the midline, right? And only if axial, proceed with Hertels. So what are the different types of exophthalmometry clinically? Absolute and relative. Where you refer to it absolute when it is bilateral and more than 21 millimeters, and relative when there is a 2 mm difference. There is a concept of comparative exophthalmometry as well, where there is said to be an increase with follow-up visits. Gold standard is Hertels. The arrow mark that I put up here is to show some precautions that you are expected to follow when you do the examination. So these are some pictures of various exophthalmometry, and certain variations happen in pediatric cases. Important ocular signs not to be missed in conjunctiva, cornea, sclera, pupil and IOP, Braille sign, differential IOP, and last but not the least, classification versus scoring. Remember one point, this is all I want to convey here. Visa and clinical activities score is for clinical activity, whereas no specs and UGOGO is for clinical severity. Note the difference, right? Grading, you can always remember it from, just before the exam reading up the charts. So no specs, CAS and UGOGO are important gradings, and lastly the visa classification. So due to shortage of time, I'll wind up with this. So take home messages as follows. Cover all aspects of examination, have the right instruments. The examiner could simply ask you for 2 rulers, even if you are having a case of thyroid orbitopathy. Assess the severity of disease with the best possible tools and give a complete full diagnosis with etiology. Thank you.
Thank you, Niranjan. Really, it's a great talk. I'm actually proud of him. So, thank you. Actually, this topic was given to some other doctor, and she was not able to come. The reason is, and I will try to present as simple as possible. All of us know that we have got one thing called visual axis. That is a line connecting the object, passing through the nodal point. The nodal point is where in the lens, posterior part of the lens, and goes to my fovea. That's called visual axis. Object, nodal point, fovea. This line is called visual axis. Right eye has got one, left eye has got one. So notice this visual axis should maintain some equilibrium. If the alignment is deranged, it is called squint. That's all. If the alignment between the visual axis of both, either the physiological relation is not maintained, it is called squint. Squint can be of so many reasons. I'll tell you one thing. Now, afferent pathway from refractive errors, cornea, opacity, like you can have macular problems, optic nerve problem, that is going on up to the brain. That's called sensory problems. So anything affecting your sensations, reaching your brain, you will develop squint. Please remember, this is called concomitant squint. What is that? Sensitive problems. Here, what's the beauty now? The efferent pathway is normal. The movements are normal. That means what's the classical difference now? Diplopia may not be there in these patients. Diplopia may not be there in these patients. Of course, rare exception is there, but usually, whereas efferent pathway is involved, a paralytic is called incomitant squint or paralytic squint. The muscles are paralyzed. That movements are problem. They will experience diplopia. Understand now? To overcome diplopia, they will have hip postures. Adaptation of hip postures and all. That means what? When you see a person is having hip posture and is having squint, think about the problem maybe in paralytic squint. It's not concomitant. Very rarely you can have. Like so many things are that different. But usually these are normal things. Understand now? What I told you. What is crooked now? What is a squint? Misalignment of visual axis. Misalignment of visual axis. That is a physiological relation is not maintained. Say, I can have convergence, I cannot divergence, so many things. But they have to maintain some relation. If it's altered, it becomes squint. Understand now? I already told you, concomitant mode, the sensory pathway is a problem. Sensory sense reaching my brain is problem. That's called sensory. Here we got tropias. When I see the person is having squint, man, right eye is deviate out, left eye I know from outside. But when you see now, when you see the person is having no squint, eyes are normal. When you cover one eye, that means the impulse from the eye is not reaching my brain. So the right eye brain impulse goes to my brain, left eye impulse goes to my brain. They are fusion. So when the fusion is prevented by covering one eye under the cover, this eye may deviate. When I uncover, again the eyes become straight. That is called 4 years. That is called 4 years. Latent squint. That means you are bringing out the squint out by putting a cover test, that's all. There are so many tests for that. Just know this. Cover test is mainly to bring out the squint. That is 4 years. And of course, other things also, trophy also you can find out. But mainly to bring out the 4 years, you have to do something, alternate cover, whatever thing is there, you have to do this. Chief complaint what patient will come to you what diminished vision. You know, diplopia is there, patient will come and tell you, sir, I am loss of vision. Tell them because they are not aware. They will have false images there. They will think, sir, right eye for diminished vision, they will tell you. So you have to be very careful in that case. Head posture, I told you. By seeing the head posture, you can know which muscle is involved. Very easily you can tell in the exams. Suppose the right eye, for example, I want an example tell you. Only one muscle you will be asked in the exams. Only one muscle. A normal examiner should ask you. Normal examiner, please remember this. That means superior oblique. Superior oblique is the only muscle which is supplied with single nerve. There are 3 different actions and the 3 different postures. Superior is what? Oblique is what? Depressed or chin is depressed. But the tilt and turn, please never forget in superior oblique is always towards sound side. But suppose right to superior oblique problem is there, head is tilted towards the left side. Head is turned towards the left side. That is the only thing you are supposed to remember. Don't bother about other muscles. You'll get confused. But most important, of course, lateral rectus muscle, turn to right side. That's enough. That's okay. Right or left, you know, only horizontal turn. But tilt and all these things classically can affect your vertical muscles. But most important is your oblique, superior oblique. I told you, normal examiner should ask you one superior oblique. Okay, you tell the examiner straight away. Okay. Devolution, age of onset, of course, for birth restore problem is there. All these things, you got infant lysotropias are there. So many problems are there. Is a constant intermittent. Sometimes it can comes and go. That's what you got. Intermittent squint is there. Like that you can just see the patient and tell you. That's all. You ask the histories. Past history, classical refractive errors. The patient might be having glasses and all. Myopia patients in future may develop a problem of divergent squint. Hypermetropy patient in future may develop a problem of convergent squint because of excessive accommodation. Because hypermetropes cannot see distance and near simultaneously. Because we cannot see both. That's the problem with using accommodation always to see even to see distance. That's why his accommodation is coming into play. He will go in for convergent squint. This is what I'm supposed to know that. That's why certified it is a must. You ask for any history of any surgery was done for the patient. Any occlusion therapy was done. You know, these are all, any squint case, man, just a patient has come to you. You just see the visual acuity, dilate the pupil, see the fundus, and do retinoscopy. If a problem is there, if suppose visual problem is there, something is there, you do amblyopia treatment. Then you can think about giving a penalization, whatever thing is there, treatment for amblyopia. Then you can see prism test, prisms and all, you can use it. Then finally you can go for surgery. Don't tell straight away surgery. Understand now? That means what? Any case of squint comes to you, you have to tell this in the way. Dilate, see the fundus, retinoscopy, refraction, amblyopia is there, correct amblyopia. Then any prism is required, you can give prisms, glasses can be given. Understand now? Then you can give surgery finally. You have understood? Always see the family members. Suppose surgery is done, see the family members. Family members may be having squint. You do not know. And they might have done surgery for him. The surgery may be successful or not. We do not know. That's why always remember, you have to examine a person, a squint, always examine the family members. Family history. I already told you, head postures and all. Remember, facial symmetry, ptosis, examinations, never forget visual acuity. Never forget visual acuity, I told you. Hirschberg test, everyone knows that. See now, the light is falling on the pupil margin means you are normally 15 degrees. Away 25, then 30. But here, one tricky question will ask you in exams, what is the diameter of the pupil will ask you. Suppose you tell the diameter of the pupil 3, now the light is reflected in the falling in the pupillary margin, it cannot be 15. See, 1 millimeter only 7 degrees. If it is 1 point, from center to margin, the people 1.5. If 3 means 1.5 only. 1.51 to 7, how much? It will be only 10 or something. So always never go to confusion. That means always people in the margin is 40. It's not 50. It depends upon the size of the people you are supposed to instill in the exams. Fishback test and all, cover test. Always remember, cover test, alternate cover test and all you are supposed to practice. What's happening to the uncovered eye, what's happening when you remove the cover, what's happening to the eye under the cover, like that, all these things you can just, in 10 minutes is impossible, but squint you have to take at least 1 week. Then only you can take proper classes. Then only you will understand what is squint. Otherwise you will run away. Hello. You will run away from squint. Just know, never forget about this. These are all the various things. Krimsky means what? I'll tell you. Krimsky tells me you are putting prism man to find out how much of deviation is there. But Krimsky means you are putting prism in front of the deviated eye. Suppose I'm having esotropia is there, your apex always ISO. That means base out. Apex to be always seeing the deviation, base out. You are going to find out. So Krimsky is what? Putting the prism in front of the deviated eye. What is modified Krimsky means? You are putting the prism in front of normal eye. Okay, keep on increasing the power so that other abnormal eye will become straight. This is what modified Krimsky is. Krimsky I told you, modified Krimsky I told you, remember? 4 years, say any case I told 4 years to find out 4 years for near. If I got one test called Maddox wing, Maddox rod with a tangent scale is there. That is for squint, fovea is there for distance or not. Very simple, man. Suppose, in this case, right eye sees from right side hole and the right side will see only the arrow. Left eye will see the numbers. Imagine you are a normal person, you will see the arrow and zero in same area. Suppose my right eye is deviated somewhere, that means please remember, eyes are looking straight. When you see through this test, the arrow is shifted. That means what? You are breaking the fusion by giving different pictures. Right eye seeing an arrow, left eye seeing a number, brain cannot fuse. That's why the eye is getting deviated. That's why when the arrow is coming to right eye, right side, esophoria. Left side, exophoria is going up. Always remember, when the arrow goes up, that means the right eye has not gone up. That means the right eye at lower level. Left hyperphoria. The arrow has come down. That means right eye has not come down. Left eye has gone down. That means for right eye higher level. Like very easy to remember. Understand now? Very easy. The eye has not gone there. Finished. Like this. Remember like this. But never forget, patient, don't tell right eye esophoria. Left eye, don't tell. You tell patient is having esophoria. Finished. Patient is having, same thing can happen with the left eye also. We do not know. So that's why you always tell esophoria, like this. And never forget you do diploid by charting. You understand now? All these things. And you have got, whether the patient has got adaptation, sensory adaptation is there for squint, like abdominal correspondence. Sensory adaptations are there in the patient. You have to find out. There are so many tests for that. What 4-dot test, so many tests are there. That means you have to find out abnormal little correspondence is there or not in the patient. This is the most important thing. This is what 4-dot test you can use it. Then we got other after image tests. So many tests are there for abnormal correspondence. These are all very simple things. But once you go and read, it's a very easy things. Understand now, one of the easiest subjects. Again I tell you, squint. My advice to the students, never bother about examinations. Don't bother. Go inside. Hello. With a clear mind. Okay? Examine the person, see the signs, write it, present. Don't bother about diagnosis. Don't take any clue from anyone in the hall. Don't take any clue. If you take a clue, you are finished. Because your mind will be misguided there. You keep on thinking the same thing. Suppose I tell you, is a case of papilledema is there, you go and see the patient is not having papilledema. You think what is the case of papilledema, you keep on telling papilledema in the exams. I've seen students telling like this. How to follow? So take your own time. My best wishes. Thank you very much. Now I call upon my great friend, one of the my mentors. Hello. What? My mentor, Dr. DC. Hey, we have got a online free course, VRV DC online course. If anyone wants, you can join. We are conducting every week classes.
Respected VRV sir, sir is telling the other way around. I have been a student since 36 years and I continue to learn from sir. Thank you so much, sir, for this opportunity. Thank all the people who have come here to learn. I'm sure it will be useful. In the next 10 minutes, I'll convey to you some important aspects of retinoscopy. Ultimately, the foundation of an eye hospital or an eye clinic is to give the best vision. You all agree? And the most important is the optometrist and the refractionist, and you must know what they are doing. So I'll skip off all this and just talk about the refractive status. So you can assess subjectively or objectively. More important would be to find out exactly by objective method. One of that would be retinoscopy. This is the father of retinoscopy, Ferdinand Quignet. He started it in 1873. In retinoscopy, it's otherwise called skioscopy. When light is reflected from a mirror, or now we use the self-illuminating retinoscopes to find out how it works and where the image falls for us to find out what is the power. 3 stages. First is the illumination of the retina, then the reflex, and where it is getting projected. That will determine how it is. So what we use is the Welch-Shallin model of self-illuminating retinoscope. You keep the sleeve down, only it is a plain mirror. If you put it up, it becomes a concave mirror. Reflexes will change. Concave mirror is only meant for high myopic powers. Otherwise, by default, you use only the plane mirror. Dry is without a cycloplegic, wet is with cycloplegic. And if the patient is looking far away and you do without a cycloplegic, it's called static. If they are looking into the light, it's called dynamic. So the working distance is ideally 2/3 of a meter, which is your arm's distance, and the 1 meter is for practically to calculate during your learning stages. Now this is a model eye where you can practice. Here you can see how the reflex is moving. You can see beautifully the reflex moving with the movement. Now there are a lot of things. If the speed is faster, you are closer to the neutralizing point. If it is brighter, you are closer to the neutralizing point. Then like that, and the width become narrower and crisper when you come to the neutralizing point. We will not talk about this, you understand this. Only when the image falls between the patient and the observer, it will be against reflex. If it falls at the observer, it is a neutralization point. Everywhere else it will be with the movement. You go through, I think it will come in the notes also. Here you can see with the movement, against movement, and neutralization point. Now here you can see clearly, what do you see? With or against? Pardon? Yeah, you can see very clearly it is with. Now you are seeing what? So this you try in the model eye. Don't sit in front of a real patient and try for half an hour. You learn and then you can go into the patient. So these are the two important movements. So what are the signs of neutralization? The whole pupil will be filled, no movement, and when you put additional 0.25, either it will get reversed, positive will, with will become against will become with. These are the simple things. Now I will go straight away. See, for a oblique astigmatism, which is not 90-180, 3 things are there. This is called the break. 3 beams, no, one on the iris, one in the pupil, one. It will not be straight. It is called break. And here, there is a width. If they are away from it, it will be wider. If it is in the same axis, it will become narrower. Intensity will be brighter, and skewing. I will show you what is skewing. Here you can see one will move in one axis, the other. It doesn't move parallelly. This is called skewing. And then just like your Jackson cross cylinder, you move 45 degrees on either side and see. This is to confirm the axis. Difficulty, all difficulties are the most important was the scissors reflex, where you can see the scissorsing. Can you see? One is moving with, the other is moving against like a scissor. This is the scissorsing reflex of a keratoconus. Drug correction you give for only spheres. Exceptions are mixed astigmatism, pseudophakia, aphakia, and presbyopic. Wherever there is no accommodation, we don't give at all. Never give for minus spheres or cylinders. Now I will come to this is again minus at 180 and plus at 90 with the rule. Opposite is against rule. These are the basic things. So we will teach normally 8 steps of retinoscopy. This is what you get out of your retinoscopy. This is called power cross or the retinoscopy value. 90 degrees it is 30.5 and 180 it is 2.5. Then what do? You sit at a distance of 1 meter, then you make a correction of -1. Plus 3.5 becomes plus 2.5. 2.5 becomes, this is the distance correction. Supposing minus 3.5, you put -1, it will become minus 4.5. Just remember that. So this is the first step, second step. Third step is this distance correction. Then you call it subjective. What do you take? Take the smaller power as a spherical power. So here we have taken 1.5 as the spherical power, and I have got 1.5 all around, that is the spherical power, but I need to get 2.5 at 90. So I will give It will act in the opposite axis. I will give a plus 1 at 180. So it will become plus 2.5 at 90. So this is the subjective value. Now what is the idea? Both are equal powers, but the minus cylinder is better acceptable than a plus cylinder. So how will you transpose? Add both, plus 1.5 and plus 1 is equal to plus 2.5, and reverse the sign and the axis. It will become minus 1 at 90. This is a simple spherocylindrical transposition. Okay. Now I have got the same power with a minus cylinder. Now what did we use? Do we have drug correction? Nil. Age is also more and we have no drug correction. Near vision, for the age we have to give age corrected. At 40 you give 1, 1.5 at 45, like that we go. That is age corrected. But for a watchmaker or a goldsmith, we do the scientific method of drug correction, near vision correction. So this is the transpose, plus 2.5 minus 1, 90.66, and add 1 plus 3. This is how you write the prescription. Don't just write plus 1 add. No, you write this properly. Now what will be the diagnosis? Quick, 15 seconds. Anybody? What's the diagnosis? How many of you want to say it's mixed astigmatism? Simple astigmatism. Come on, man. Anybody? Yeah. Okay. This somebody will tell it is mixed because there is one plus sphere minus. Remember, this is a compound hypermetropic astigmatism. Minus at 90 is against rule and presbyopia. These are the 8 steps of refraction. Okay, you got it. I'll just sum it. This is another one. 50 years plus 1.5 and 0.5. Okay. Now what happens to the distance correction? Can anybody tell? 1.5 will become 0.5. And remember, plus 0.5 will become minus 0.5. Okay, plus 0.5 and minus 0.5. Subjective, I have taken a plus 0.5 because I want a minus cylinder. I took plus 0.5. So plus 0.5 is there all around, but I need minus 0.5 at 180. So I have to compromise that plus 0.5. So you add, so minus 1 at 90. By giving minus 1, you compromise that existing spherical and get minus 0.5. Then already you have a minus cylinder. If you transpose, it will be like this. Here it is not necessary to transpose because I want only a minus cylinder. Drug correction will be nil here because it is mixed, and near 50-year-old, near vision 50 years, we are giving an age corrected plus 2. So the glass prescription is like this, and the diagnosis here is a mixed. There you said compound. When the cylindrical power is more than spherical, it is mixed. When the spherical power is more than cylindrical, it is compound. When both are the same, they are called simple. Here if you transpose, you can see that. Okay. So compound is spherical more than cylindrical, mixed is cylindrical more than spherical, and both are equal, it becomes a simple astig. Okay. This is the near vision correction. I have 1 minute. So normally for hypermetropia, you give manifest plus 1/3 of latent. In scientific method for distant, it's also called near vision. So you have to calculate what is available power. You need what power is needed and keep 1/3 reserve. I'll give you an example. Watch mechanic reads at 167. What is his power? 100 by 67, isn't it? So he has a power of 1.5 adapter. To read at 25 centimeter, 100 by 25, I need 4. So normal tendency is 4 minus 1.5, I'll give 2.5, isn't it? But available power, you keep 1/3 reserve. What is that? In 1.5, you keep 0.5 reserve, then I have only effective 1. So I will give a plus 3 adapter power. You go and think. This is the scientific method for giving for your goldsmith or your watchmaker. And these are the ways you can do. These are other examples. And this is overview of retinoscopy. Thank you so much, sir. Once again, thank you all.
Thank you, Chandru. Very nice presentations. And we have got one program that is the Dr. Chandrasekhar, the instructor, chief instructor, on today itself, 11:45 at trade number 2, trade room. If possible, please come. Optic disc. Okay, thank you. Any questions for Chandrasekhar? Yes, Dr. Loganathan. Is question irukka? Professor. Suma relax and hello, enjoy. Again, I'm telling you now, don't bother about examinations. Prepare yourself. Theory means read standard textbooks. Journal, if possible, you try to read. That's enough. Then, clinical case, straight daily see patient and present to your seniors. Don't bother about the same patient presenting to different examiners. Doesn't matter. At least you get exposed. At least our branch of medicine, whichever branch of medicine, no need for intelligence. Only mathematics require intelligence. Here we need hard work and memory power. Keep on reading, reading, reading. Anybody can do that. So naturally, you keep on reading. At least present cases to other your seniors. You try to learn. That's enough. Okay. If possible, to contact Dr. DC for his free online course, if possible.
Any of you can join. It's a weekly and monthly regular online, no recorded versions. You have to attend live. You are all welcome to join, and wishing you all the best. God bless you. Thank you. Sir, sir.
If you have any queries, suggestions, you're most welcome to ask us after the IC as well. We will wind up for the next session to start.